Thank you, Mitzi, and thank you, Cheryl and Yvonne and everyone from ZOLL. Again, we appreciate ZOLL's sponsorship of this educational event. Again, really nothing to do with anything that ZOLL makes. This will be dealing with pacemakers and implantable defibrillators. We'll have two talks today. The first one will be about a half hour or so, and we'll be hearing about advanced pacemaker ECGs and troubleshooting. Again, we'd like this to be quite interactive, and this will be from Dr. Gurjit Singh, who is the director of the Cardiac Electrophysiology Laboratory at Henry Ford Hospital. Our second lecture will be about an hour long or so, and that will be pacemaker and ICD cases from Dr. Hemel Nayak, who's from the University of Chicago. So without any further ado, take it away, Dr. Singh.
Okay, thank you. Good morning, everybody, and thank you again, Zoll, Mitzi, and the team, Dr. Verdino, for having me on this talk. So my talk is basically about whatever you guys have learned over the last two sessions. So we're going to test those pacemaker ECGs, and Dr. Nayak will be talking more about the ICDs. So as he said, we're going to keep it informal. I'll be asking questions, so if you can answer straight over the video or in the chat box, I'm fine. So let's start. So just the key points, whenever I teach fellows, everybody, keep things easy, right? So take your time in reading device ECGs, read as the way you do any other ECG, start from one side to the other side. Start with something which you know, so find a pace beat and then work around. The moment you see a device ECG, the timer's clock should run in your brain as well, just the way it runs in the pacemaker. So the AV delay timers, the P-warp, those are the main ones which should keep running in your brain to figure out, what pacing spike is going where. Pacemakers devices rarely fail. So it's very hard that you see an abnormal ECG and is because of device malfunction. So if you see any device ECGs and something not making sense, is either due to some algorithm working or the lead is failing, fracture or whatnot, oversensing or undersensing. So usually those ECGs will fall into one of these categories. And again, keep it simple. EP is easy peasy, EP, right? All right, let's go. So first case, this is an ECG showing some pace complexes. And I want somebody to volunteer and tell me what else do you see besides the atrial pacing? And wait for 5 seconds. If no response, then I'll take over. Okay, so everybody, can you guys see my cursor on the, let's see, can we see my cursor? You can see my cursor. Okay, so everybody see here, there's an atrial spike and there's a P wave following the atrial spike. So there is definitely atrial capture. And then you're muted for some reason. Can you guys hear me? It says I'm muted.
Yes, we can hear you.
We can, okay. So you see an atrial pacing spike, and definitely there's atrial capture, and then there's a QRS. Now this QRS does not look like a paced QRS. Now you can argue maybe by IV QRS, but look carefully at the peak of this QRS. The next slide will show. At the peak of the QRS, you will see there's a pacing spike actually. So there is something going on with the ventricular pacing spike. So what that is, so clearly this pacing spike is happening after the QRS has begun, which means it cannot be a paced QRS complex. So what this means is, if you should not see a pacing spike if there is a underlying rhythm. So this goes down to the fact that this pacemaker, the ventral lead, is undersensing the ventricular signal, correct? Now that's one thing. So let's look at the more details. So you have to enlarge the ECGs, and if you look at the time from the paced atrial complex to the beginning of this ventricular complex, that's around 300 milliseconds. So clearly the pacemaker is programmed with AV delays, which are not traditional AV delays. So if you look carefully, this is a DDD pacemaker with a paced AV delay of 300 and sensed AV delay of 270. So the paced AV means when you pace in the atrium, the AV delay is 300. If the pacemaker senses its own P waves or sinus P waves, then the AV delay will be 270. So what's going on here is actually the pacing timing or the AV delay programmed is pretty much the same as the patient's own native AV conduction. So remember, in a pacemaker thing, the pacing lead will have to take the signal. It has to be amplified, it has to be filtered, then rectified, and then it has to meet certain threshold criteria before the pacemaker makes any decision. So doing so takes time, and usually that time could be anywhere from 20 to 30 milliseconds. So if your paced AV delay is programmed pretty close to your native AV conduction, you can see this kind of ECG where what we call this as a functional non-capture. So it's not that the pacemaker is going wrong. Pacemaker is doing his job. It's just the way you told the pacemaker to deliver the ventricle signal at the same time, which happens to be close to the patient's own conduction. So this is an example of a functional non-capture due to prolonged AV delay. Okay. Next question, what's going on with the P's here? So you can all see there is a paced QRS complexes, and then there are P waves, which are all over the place. They are not correlating with the QRS. So what can you tell me, or what kind of pacemaker programming mode is this one? Okay, so from our last talk, if you remember, when the ventricle is being paced at a regular rate and it is not responding to the atrial signal, so either you are programmed in VVI mode or it's a DDI mode, correct? So let's look carefully. So there's an 85-year-old female who's coming with fatigue dyspnea, has a Medtronic pacemaker, and if you look at the rate, the paced ventricular rate is 65. So a Medtronic pacemaker, you cannot program a Medtronic pacemaker to 65 beats a minute, because that number is designed to show that the pacemaker has reached ERI, okay? So the moment you see a 65 paced ventricular complexes, it's a Medtronic pacemaker at end of life or ERI. So this patient is in AV dissociation because at the end of life, the device goes to a VVI mode. It stops storing signals, it stops responding to the atrial channel as well, okay? So this was the ECG before when everything was all fine. So this pacemaker is at end of life. And you should have the slides in your booklet. Basically, when you put a magnet on any pacemaker or devices, all the pacemakers will start pace asynchronously based on the device company. A Boston will pace at 85 beats a minute at end of life, a Medtronic at 65, and so on. Alrighty, going to the next ECG, what is the atrial lead sensing? So here you have a Boston Scientific pacemaker. The top channel is the atrial channel. The bottom channel is the ventricle near field electrograms. And the bottommost one is the marker channel. So if you look carefully, the first marker channel says A pace, followed by another spike, which is being recorded as A sense in the refractory period. And then there's a third spike on the atrial channel, which is being called as a PAC. And what we're doing here is, I believe this is a threshold testing going on. So it starts at 2.1 and goes all the way down to 1.8. Anybody wants to take a guess? What I'm asking is, what explains this middle spike on the marker channel? Ralph, is anybody responding in the chat, or?
We have one saying that there's a ventricular signal sensed by the atrial lead. Someone else says that it's oversensing. And then one is FF, which I'm not honestly sure what that means.
Far field. Okay. So yeah, folks are getting it right, but they're getting it right on the third spike. My question was about the second marker event. So the third marker event is correct. I mean, that's a ventricular signal being sensed on the atrial channel. So that's a far field signal. So that is correct. But the question is, what is this middle thing? Okay. And if you look carefully on this ECG, as the pacing output is reduced, that middle signal goes away when you're at 1.8 volts. So I'm going to go make it easy for you. And then we're going to go next. And then here, if you look, as the pacing output is going down to 1.5, 1.4, that middle signal is gone. You still have the far field signal from the ventricular channel. So what that extra channel is, it's some kind of sensing. So what kind of sensing is that? It's called a polarization artifact. It's not that common to see this, but it happens whenever you pace a lead at a higher output. you can have local ionic changes at the tip of the pacing lead, which will stay or create their own electrical signal called evoked potentials, which may be sensed on the pacing channel. So that example actually shows you a polarization artifact. Usually that happens at a very high output. For this patient, it was happening at around 1.9 volts as well. So the second pacing spike or second Markov signal is from polarization artifact. And the third one, as everybody has picked it up, is the far field signal seen on the atrial channel here. Okay, now, and that's far field signal. It's called crosstalk. All righty. Now, why that happens, as Dr. Upadhyay explained last time, and so this is a example of an X-ray showing the atrial lead is sitting in the appendage. So normally we try to put the leads in the appendage, right? And here an example on a pig heart I'm dissecting here is showing you the right atrial appendage, has all these projections, which sits on the AV groove, and some appendages could be long, some could be short. So that's the reason if your lead is sitting screwed in right at the tip of this appendage, you will have a far field signal from the ventricle. So that's the reason for far field crosstalk. Okay. As shown here also, you can see how close the appendage is sitting to the right ventricular outflow tract. Okay, next question. Pacemaker is behaving erratically. 70-year-old male with hypertension, pre-syncope, sick sinus syndrome, underwent a Medtronic adapter pacemaker, and this is the ECG. Anybody wants to take a guess what's going on with the pacing?
You can write it in the chat. We have one vote for MVP.
Okay, perfect. Yeah, whoever said that is obviously in tune with the pacing ECGs. And remember, I said, keep these ECGs simple. Either is some fracture going on, some algorithm working, or some undersensing and oversensing. So this is a Medtronic pacemaker in MVP mode. So I'm going to label this for you. So the first three complexes are A-paced, followed by a patient's own QRS. The fourth A-paced, you see a captured atrial, but there is no ventricular signal. And then you have another A-paced at the paced program pace rate. And then the ventricular pace comes at 80 milliseconds. So remember, we talked about last time, as Dr. Verdino also explained. So this is a hallmark for a Medtronic pacemaker in MVP mode, that this ventricular pace signal comes after a AV delay of 80 milliseconds. This is different from safety pacing, which we discussed last time, which happens when you sense something on the ventricular channel at the time the atrial is pacing. That safety pacing is usually 110 milliseconds. So this is MVP working. You see 2 out of 4 atrial complexes losing conduction, and the pacemaker switching to DDD mode. Okay, so this is MVP in action. Again, briefly, MVP is AI pacing, AI mode going in the atrium. The moment you lose conduction, 2 out of 4 beats, you switch to DDD, you wait for a minute, and then you go back to the same AI mode. This is to prevent and minimize RV pacing. Okay, next slide. Noise, noise, noise. I'm labeling it for you. So you see a Boston Scientific pacemaker with an atrial channel and a ventricular channel. And this is an example of how the noise should look like. This is a non-physiological atrial signal. Even if you're on AFib, it's very rare to have an A to A or an A to A interval under 120 milliseconds. I have recorded a patient with an atrial in AFib as close as 80 milliseconds. But you see, if this would have an AFib, then it should be continuous electrogram. This electrogram comes and goes, comes and goes, comes and goes. And if this is a brand new pacemaker, then first thing which should come to your mind is, anybody? Okay, nobody's answering. So this is an example of a loose set screw. Somebody forgot to put the lead in properly, and you should do an enlarged X-ray, and you see in this case, the bottom one is the ventricular channel, the top one is the atrial channel. The atrial screw is not all the way pushed in. So this is an example of a loose set screw. So usually this happens immediately or within the first couple of months after a device implantation. Rarely see this after many, many, many years. Okay. The other reason for this noise could be a fracture also. Okay, next case is a patient with a ventricular pacemaker, and you can see patient is being paced at 60 beats a minute, and then something else happened at the end. Anybody want to take a guess what this is? Ralph, anybody's answering the chats?
Not right yet.
Yeah.
Give them a second or two. It takes a little while. The last one we had some come after you had get started. Anyone would have
Is this
guessed?
VT?
So someone
VT, is it ventricular fibrillation? Yeah.
dislodgement or artifact?
Artifact. Okay. Well, artifact is probably not the right term because the device is sensing something, right? So, but
Someone else said electrical interference, maybe?
right, electrical interference. Yeah. So electromagnetic interference, which could be external or internal, could be any of those things. You're correct. And this signal, if you measure this V to V signal, is very, very, very fast. Okay. So this is non-physiological. No human heart can beat at 800 beats a minute. So obviously this patient is likely pacemaker dependent, and this, whatever this artifact or this electromagnetic interference is being sensed, and the patient is actually asystolic. So this is an example of an EMI, could be anything external or internal, but this is not VT on a pacemaker. Okay. What else do you see? I was going to show you is basically the patient is asystolic here. Okay, on the same theme, there's a next patient. This is a patient I saw a couple of years in the clinic, 46-year-old obese, morbidly obese guy who had AFib and had an AV node ablation at an Austin institution at age 46, has a St. Jude pacemaker implanted in 2010. And I saw him, I believe this is 2016 or so. Pacemaker programmed at BVIR at 60 beats a minute. Sensing is pretty good. Impedance bipolar is 430 ohms, and his threshold at the time of implant was 0.75 at 0.5 milliseconds. So with that history, this is his ECG, showing you that he's an AFib and RV paced with the pacemaker complex left bundle Peter axis. And this is when I interrogate his pacemaker, I found this. So the topmost part of a St. Jude device here is showing you a far field or a discriminatory electrogram. The next one is his near field RV electrogram, and the third one is his marker channel, and the fourth one is the timings interval. Anybody wants to take a guess what's happening in the first part of this ECG?
We have a noise, oversensing.
Okay, very good. So yeah, that's correct. It's a noise which was being oversensed as a non-physiological signals again, causing, remember this patient has AV node ablation done. So whatever this thing is happening, the pacemaker thinks there is a QRS activity and it stopped pacing. So this patient is actually passing out or becoming dizzy, lightheaded in a patient who's dependent. So, and this patient kept doing this for multiple times. And sometimes the noise is very subtle. It does not have to be all the time that very, very fast and rapid signals. But regardless, something is being sensed on the ventricle channel and is inhibiting pacing because he's in VVI mode, right? So this is an example of a noise. Now, why the noise occurs, as I said, could be loose set screw, but this pacemaker was implanted almost 6 years ago, so it cannot be loose set screw. So what else comes to mind is a lead fracture. So what you do in the pacemaker clinic or in your clinic, you have the patient do isometric exercises. So these are various examples where you tell the patients to pull their arms toward one side, pull them apart. So these are examples of doing isometric exercises, and you're supposed to look at their electrograms to see if you can bring on the noise in some particular fashion. Usually there is a lead fracture in the clavicle. So we did the isometric exercises, and clearly you can see we were able to bring out the noise, and it inhibits pacing, and there is ventricular asystole. Now this could be bad also. The ventricular asystole, if it prolongs, can become VF as well from bradycardia dependent VF mechanisms. So what do you do? So how do you fix this patient in your clinic? So what you can do is either you can program him VO, he's AV nodal ablation, or basically you raise the fence or lower the sensitivity or decrease the number, increase the number and lower the sensitivity. So this is all about the sensitivity where you can, whatever pacemaker can see. And you get an X-ray, and I got an X-ray on this guy, and you can clearly see that there is a break at the entry level into the subclavian. So this is called what we call the clavicular crush. Can happen if you implant a lead through the subclavicular ligament. So that's why we should always avoid putting a lead through the ligament, because over the time, the ligament will cut through the lead. So this patient required a brand new lead. Okay, Next question is, we have a patient with a pacemaker and we're trying to do atrial threshold testing. I'm pacing the pacemaker at AAI 100 beats a minute. And why I'm not able to do the threshold testing? Anybody wants to take a guess? Okay. So again, you're pacing, I told the pacemaker to pace at AAI 100 beats a minute. So I labeled these numbers for you. So this first atrial pacing as shown on the marker channel, and the second atrial pacing on the marker channel is at 600 milliseconds, which is 100 beats a minute. There should be another third atrial pacing at 100 beats a minute, but it's not happening. And the reason it's not happening is because the pacemaker is sensing something. Because remember, you are pacing in AI mode. If you see something, you are not going to pace. So this is an example showing you the far field signal, again, crosstalk from the ventricular being sensed on the atrial channel. And that's the reason you cannot complete your threshold testing. So to complete this threshold testing, what would you do? Okay.
So we have changing the rate, but we have decreasing the sensitivity.
Okay. So changing the rate will not help because you're gonna the faster the rate or the slower the rate, you will still sense the ventricular activity on the atrial channel. But yes, we have to decrease the sensitivity, which means you have to raise the fence so you don't see this far field in the atrial channel, and you can complete your threshold testing. Okay, so that's absolutely. So this is an example of, again, oversensing or far field testing. Okay, and so again, far field I labeled for you. So then again, the reason is because the lead is very close to your ventricle. Okay, so you increase the fence, and then now very nicely you can pace the atrium at whatever rate you want, and all those far field will not be sensed now. So you can clearly see here is A pace followed by the V sense, A pace, V sense. So this is the threshold testing. So sometime this is an example to show you that the device clinic or may come back, patient lead is failing or the threshold is high. And the other way to do is, if you have any trouble, obviously this is not a dependent patient, you can always test in AO mode. AO mode is basically you are turning everything asynchronous. Okay, next patient is a 75-year-old male with palpitations. Keep coming back to the clinic with this ECG. Anybody wants to tell me what's going on or give me an example of what this could be?
Nothing yet.
Okay, I labeled the rate for you as 125 beats a minute.
So we have some PMTs, upper rate behavior.
Perfect. So yeah, so anytime your pacing rate is close to these 120, 130, which is our usual upper rate programmed parameters for, especially for people in above 75, 80 years of age, PMT should come to your mind. Obviously, some kind of atrial tachycardia or flutter or upper rate behavior should come to my mind. Okay, so let's see what happens. So this patient is programmed in MVP mode, and his upper track rate is 130 and upper sensor rate is 130 beats a minute, paced AV delay of 180 and 120. Okay, but so this was his behavior in the clinic. It shows you here he have a sensed atrial beat followed by his own QRS with the fusion going on, then another sinus beat with the ventricular pacing, and then he's off to this rhythm here. If you look carefully at your 12 lead ECG, if this is a PMT, remember PMT means there should be a retrograde VA conduction. So the P waves, if you're able to see them, they should be negative in lead 2-3 AVF, should be positive in lead 1 and AVL, suggestive that something is starting in the mid part of the atrium and going towards the left side. So this is an example of PMT, and how it starts is your AV node is available for retrograde conduction. So shown here is that ventricular pacing spike is going back up the atrium, and that atrial signal is being sensed, and then the cycle starts. Okay, so shown here again, usually it starts with the PVC. And then this cycle goes on where you V-pace, ascends, V-pace, ascends until one of the atrial signal falls into the refractory period, okay? So that can happen spontaneously and that will terminate the tachycardia, or a PMT algorithm will work. So what the PMT algorithm usually does is it prolongs your PVARP for a certain duration of time, and to see if the atrial signal falls into the refractory channel. And if it does, and the tachycardia terminates, that usually is a diagnosis of PMT, okay? So again, a pacemaker-mediated tachycardia, I'm sure somebody must have covered that. You have to have a retrograde VA conduction, that atrial signal is sensed, and then you keep going into this loop. So what is the most common reasons for PMT to happen is either you can have atrial non-capture. So let's say for some reason the lead failed, you pace the atrium, but you don't capture the atrium, and there is no underlying rhythm. So now the AV node never conducted. So that's how the AV node can become available for retrograde conduction. Or atrial oversense, which will do the same thing. Or usually this happens with prolonged AV delays. So especially with MVP modes or rhythm IQs, if you have AV conduction going on for a long time, the retrograde VA conduction can happen. And usually starts with a PVC or some kind of atrial non-capture episode. So this is an example of PMT. And how to fix PMT? You should shorten the AV delays. You can prolong the PVARP, turn the PMT intervention on, which is usually on for most pacemakers. And if despite all that it doesn't work, then you need to check your lead, revise leads if there is loss of atrial capture. Okay, next patient, and now we talk about PMT. Multiple PMT episodes recorded on this patient. And here is the electrogram of one of those episodes, and shown here is the atrial channel and the ventricle, and you can see it's asensed and V-pace at max track, okay? Usually PMT will start at the max track rate, and that's how the pacemakers know that a PMT might be happening, okay? So let's see how does the pacemaker intervene. So you can see again, ascends, V-pace, max track, and right in the middle of this slide, if you look at the marker channel, the pacemaker does something. It prolongs the PVARP and makes this ascensed event fall in the refractory period. In a Boston pacemaker, it will not say AR, it will say AS in the brackets. But if you look carefully, the moment the atrial signal was in the refractory period, the tachycardia never terminated. It continued on and on and on, okay? So this goes against the diagnosis of PMT. The PMT should terminate because if there is no V, well, there will be no A and the tachycardia will terminate. Here, the tachycardia continues on, which means this is not a PMT episode. This is an episode of sinus tach or an ATAC, okay? Alrighty, I think I have a few more slides, or do one more case, Ralph?
Yeah, that sounds great.
Okay, let me see. Okay, yeah, this one a good one. So this is a 90-year-old with AV block. This is patient's pre-implant ECG showing some kind of AV delays. And then this is the pacemaker ECG when he came to our attention. And I'm going to ask you what's going on with the atrial pacing or the ventricular pacing, and what would you call this ECG as? Any responses, Ralph? Because this is a good ECG, which covers a lot of things at the same time.
Yeah, not yet. Give it a minute or so. So I'm a little confused. There were two ECGs. So the first one you showed.
What I'm showing you, yeah, first one is the patient's pre-implant ECG, just showing that he does have some kind of AV block, and that's the QRS morphology. And this is this is now with the pacemaker in.
Okay. Yeah, we could see the one with the pacer in.
Yeah. Okay, so I think I'll take over. So if you look carefully, obviously, if we look at the lead V1, patient is in sinus rhythm, upright P waves in lead 2-3 AVF. And then let's look at the telemetry lead 2. If you keep going on, patient is in sinus rhythm, and then right 1, 2, 3, 4, 5, 6 beat has this pacing spike coming on top of the P wave, right? And then at the last 2 beats, the pacing spike comes before the onset of P wave. So remember I talked before, if the pacing spike is happening after a signal has started, a QRS or a P wave, that usually means it is under sensing. It did not sense that signal and the pacing output has been released. So this is an example of showing you atrial undersensing, which is a transient. Okay, then let's look at the other ones. So if you look at lead V1, before every QRS, there's a tiny signal. Now, you can argue that it could be a fractionated QRS, or is it a paced QRS? So in this patient, it turned out to be a paced QRS. Now, if this would have been paced, does this look like any close to RV pacing? No, RV pacing should be left bundle, superior axis. This patient does not have a bi-V pacemaker, and this is not a HIST lead. So in absence of those things, this means that the ventricular signal is being released, a ventricular pacing signal is being released, but the paced morphology does not look like a paced QRS. So this is an example of ventricular non-capture, or the pacemaker lead has failed, okay? So this is the pacemaker was programmed, intrinsic amplitude in the atrium was 0.8 and the RV was 3.9. And then when you test the intrinsic rhythm test, this patient has his own sinus rhythm and his native QRS. So remember, this top row here is the ECG from your programmers. So you can look at those ECG. The first 2 beats here looks like a paced morphology, and the next one is showing you his intrinsic QRS. Next, what I'm going to show you, we are pacing the ventricle at 60 beats a minute, A pace, V pace, but this paced morphology at whatever output we are testing does not look like his paced QRS morphology. It looks like his own intrinsic as shown above. So this tells you that whatever output you're pacing, the pacemaker is not capturing, okay? So this is an example of ventricular non-capture due to lead failure or whatever. And ventricular output at 5 volts this is how it should look like. And then this is the final diagnosis: atrial undersensing, ventricular non-capture, ventricular undersensing, and that's pretty much it. I think I'll stop here, Ralph. I mean, I have more to go, but I think for the sake of time.
Yeah, I just want to go back to that. I'm not totally positive. Again, we can kind of discuss, and that's one of the nice things about tracings, but I'm not sure there's atrial undersensing. It's certainly occurring in the P wave, but it's not occurring after the P wave. So sometimes it just seems that the atrial rate is slowing down a little bit. Remember that you can sense anywhere in the P wave. Now, usually the left ventricle senses first, the left atrium is the latter part, but it kind of can depend. So I'm not positive. It certainly seems that the first ones are appropriately sensed, and it seems that the rate seems to be, maybe picking up a tiny bit. So I'm not positive.
Exactly. That's a good possibility. Again, it goes with the fact that, remember, the pacemaker takes time for it to be sensed, you going through the circuit. So you're right. I mean, it could be because of that reason, the rate has changed just slightly. But I was using the example just to show this, I mean, how an atrial undersensing might look like. But you're right, given the change in rate, yes.
And that could also be possible even with the lead. It may be, with the ventricular lead, sometimes, again, especially in a right bundle branch block, imagine that, the lead is almost always in the right ventricle that you use to sense. So in a right bundle branch block, it's actually not that uncommon to have a spike in the QRS, because by the time that the impulse makes its way down the left ventricle and crosses over, it actually may fire, and it may be very similar to AV delay to your PR interval, and it's not uncommon. Now, it's really not a bad thing necessarily either. It's just kind of a waste of battery. So if you see that happening, and sometimes we call that pseudo fusion, if we see that there's a spike in there, it's really not contributing at all to the QRS, then you can really increase your AV delay to get rid of that wasting of the battery. So
correct, right. No, that's correct. Yeah, in this example, the pacing threshold was very high, I think close to 4.5 or 5. So that's the reason. But you're right, exactly.
Great.
Okay.
All right. Well, great. I think that was an excellent bunch of cases and EKGs. I think maybe we can move on to Dr. Nayak now, okay? And I would like to introduce Dr. Nayak. He is an associate professor of medicine at the Mount Sinai School of Medicine. He did his internal his medical school at Mount Sinai when I actually knew him as during his sub-internship. He was on my team when I was a resident. And then after Mount Sinai, he went and did his internal medicine residency at Columbia University, where he was also chief resident. And then back to Mount Sinai to do his cardiology fellowship, and then to the University of Pennsylvania. Also, I saw him there, but just when I was interviewing. We never got to work together there, and that's where he completed his electrophysiology fellowship. So without further ado, Dr. Nayak is going to talk about pacemaker and ICD cases.
All right, well, good morning, everyone, and welcome to the Saturday program. I want to thank Mitzi Applegate and ZOLL for inviting me to speak. And once again, it's a thrill to work again with my colleague and friend, Ralph Verdino, who I've known literally for 2 decades. So let's get this started. And this is gonna nicely follow Dr. Singh's talk on pacemaker cases and ECGs. And these are my disclosures. So this first case is going to feel very similar to you. This was mentioned by Dr. Singh. So this is a 75-year-old man who had an ICD placed 6 years ago for primary prevention sudden cardiac arrest. A single chamber Medtronic device was implanted utilizing Medtronic Sprint Quattro ICD lead. At a routine visit, interrogation revealed an aborted shock. He denied any palpitations, any symptoms, or a true ICD shock. Physical examination was unremarkable. The pocket was well healed. There was no heart failure on exam. And upon interrogation, the ICD lead impedance was 1300 ohms. The threshold was 2.2 volts at 0.4 milliseconds, which was higher than what had been previously. As sensing was fine at R waves of 12. And this was the episode of the aborted shock. You can basically see here that the patient had something that fell into the VF zone. The median cycle length was quite fast. This lasted for around 17 seconds. The device charged, but then for some reason it aborted. So let's go ahead and take a look at the electrogram in question. And you can see the stored electrogram here. Here's the complexes here. And this is the marker channel. So this is what the device is actually interpreting and seeing. And you can see here that these are what we call fast senses. And pay attention to these sort of coupling intervals here. And this is the aborted shock over here. So what would you do next? So your choices are, A, you're going to start amiodarone, 400 milligrams twice a day, bring him back in 8 weeks for a DFT check. You're going to B, make the device less sensitive so it won't detect myopotentials. C, counsel the patient on the need for an ICD lead replacement. Or D, recommend he sit further away from a 65-inch television to avoid further EMI. So in the chat, if you can answer kind of what you think ought to be done. If somebody wants to volunteer an answer, that would be great. This should be pretty straightforward from what, based on what Dr. Singh talked about earlier.
A couple C's, a few more C's, a B.
Good, great. So if you take a look back at the tracing here, you have what appears to be very, very short intervals. These are non-physiologic, right? As Dr. Singh mentioned, the heart cannot beat with this fast coupling interval. So there's certainly something here that it's being picked up. And based on the threshold being a little elevated, the impedance that's on the higher end of being normal, right? We generally think impedances in terms of ICD leads are anywhere between, let's say, 300, 400, up to around 1200, 1300. There are some high impedance leads, but in this case, this impedance was higher than baseline. We would suspect that this person had a lead fracture. And so we would counsel the patient on the need for an ICD lead replacement. Now, remember that lead fractures causes oversensing of noise, and it may lead to inappropriate shocks. And Dr. Singh had a wonderful case where not only can lead to an inappropriate shock, but it can inhibit pacing. So in someone that's pacemaker dependent, the patient suffers sort of a double whammy. They can get a shock, and then they can also have a systole. Now, lead fracture typically causes an elevated pacing threshold, pacing impedance values. And as we saw in the example, there's intermittent sensing of high frequency, non-physiologic signals, particularly when the patient sometimes assumes certain postures. And sometimes you can bring that fracture out by manipulating the patient's arm. And so many times there's a make or break type of situation or a microfracture that can really be brought on with changes in posture and position. And as Dr. Singh mentioned, the space between the clavicle and the first rib, the costoclavicular ligament, when you do an insertion where you actually have a subclavian vein puncture, you're actually going through the costoclavicular ligament over time. And in some people, that ligament is quite taut. And then over time, that lead can fracture in that location. Now, we always get x-rays to kind of look for fractures, and I think it's a good idea to do that just because it's non-invasive, it's readily available. Sometimes radiographs are not that helpful because many times it's a microfracture and you may not see anything. Okay, hold on one second. Go. All right, so let's move on to consecutive ICD shocks. This is case 2. So you have a 68-year-old man with ischemic cardiomyopathy. He underwent ICD implant in 2014 for primary prevention sudden cardiac arrest. He has not had any ICD shocks since implant. He presents to the ER with 3 consecutive ICD shocks. He denies any cardiovascular symptoms, including chest pain or near syncope. Of note, he was started on levofloxacin for bronchitis 3 days ago by his primary care doctor. So here's sort of the initial interrogation, and you can see here that the patient has received 3 shocks, 1 at 35 joules, 34, 35 joules here. The patient device is programmed where he's going to detect ventricular fibrillation at 300 milliseconds, fast VT at 240 milliseconds, and VT at 350 milliseconds. And this is an example coming up of one of his electrograms that led to this first 35 joule shock. So I'm going to take a look at this closely. So just to go over, A represents what's going on in the atrium. So V represents what's going on in the ventricle, and MC stands for marker channel. Once again, this is what the device is seeing and interpreting. So you can see here, these are sensing here, sensing here, sensing here. And here's the shock that's delivered. So my question is, what is the most likely etiology of the shock? Is it A, ventricular tachycardia? Is it B, torsade de pointes, because he happens to be on sotalol and his primary care doctor started him on levofloxacin? Is this supraventricular tachycardia with aberrancy? Is this T-wave oversensing? Or is this atrial fibrillation with rapid ventricular response, which is one of the most common causes for an inappropriate shock? All right, so if you want to answer, if someone wants to volunteer an answer or through the chat group, kind of write down A, B, C, D, E. Ralph's going to go over that.
Looking pretty uniform right now, a bunch of Ds.
Bunch of Ds, good.
Yeah, yep, all Ds.
Excellent, so this is a savvy group. So this is pretty much classic T-wave oversensing, and you can see that here. So the device is seeing obviously the ventricular electrogram, and then it's seeing this signal here, which represents repolarization, and then seeing this ventricular electrogram here. So it's sort of double counting this and considering this as a ventricular electrogram. So it thinks this person is in ventricular dysrhythmia, and then it's going to deliver a shock. Excellent. So T-wave oversensing can be transient. So many patients can get an acquired long QT, and potentially this patient being started on levofloxacin, his QT interval got long. The T-wave became a bit bizarre, and that's how the device was then able to sort of sense that repolarization abnormality. Or you may have an electrolyte disturbance if you have somebody in the hospital that is quite ill with heart failure, you're diuresing them, they get hypokalemic, hypomagnesiemic, you can have that transient QT change, and the device might be able to sense that. Or T-wave oversensing may be fixed. What I mean by fixed is that you place a lead, and sometimes the lead is in a certain location where it just happens to be picking up that repolarization abnormality, or it can change. And so one of the quick fixes or quick things that you can do in the clinic if you see something like this is, once again, changing the sensitivity in the ventricles. Dr. Singh talks about adjusting the fence. Now that is safe to do in the clinic, assuming number one, that the R waves are of normal size. Right, so the R waves are, let's say, greater than 5 to 10, or let's say at least greater than 10 or so. You can make adjustments in sensitivity and hope that, well, if the patient has a true event of ventricular fibrillation, you'll be able to sense it, right? And many times what we do is when we place defibrillators, and we used to do this a lot back in the day where we place transvenous devices and we would do a DFT check, so we induce ventricular fibrillation, have the device detect ventricular fibrillation, and make sure that the shock energy that we've programmed is enough to successfully defibrillate the patient. But when we do this testing, we used to test it in what we call least sensitive mode, meaning the worst case scenario. And so that allowed us to, when we see things like this in the clinic, to change the sensitivity if we needed to. Now, in this case, what we're planning on doing is to make the device less sensitive, so it may not pick that repolarization abnormality. But what if you're starting off with smaller R waves to begin with? Let's say over time, this person's R waves dropped and it's now around 3 or 4. Now you're going to make the device less sensitive. What's going to happen, or what could potentially happen? And what could happen is that you can have VF undersensing. So if that patient, God forbid, has a true ventricular fibrillation event, and you've now changed the sensitivity of the device to make it less sensitive, then you may not be able to effectively sense ventricular fibrillation in a timely manner. So that's something to think about when you play with sensitivity in the clinic. So if the R waves are small to begin with, you may want to consider lead replacement. Now, sometimes some devices, like for example, the Medtronic device has the ability to change sensing from a true bipolar to integrated bipolar. Sometimes that can overcome T-wave oversensing. It's not available in all vendors, and sometimes it may not work. And then, of course, newer devices have automatic T-wave oversensing algorithms, which are designed to prevent this from happening. And so a lot of these devices, like for example, can automatically have the ability to assess for this and change this. So T-wave oversensing is not an uncommon finding when you have patients with defibrillators, so something to keep in mind. Okay, case 3. The theme here is recurrent syncope after pacemaker implant. It's a 72-year-old man with hypertension, coronary artery disease. He had a PCI in 2011. Underwent a Medtronic permanent pacemaker implant in April of 2015 for symptomatic bradycardia due to complete heart block. Since implant, he has not felt right, he says, and he has noticed intermittent lightheadedness. Device checks at the time since implant have all been unremarkable, according to his electrophysiologist. Now, he was well until 2016, so literally about 5 years later, when he experienced a syncopal episode. And from 2011 to 2016, he didn't have any interventions on his pacemaker, just normal routine checks. This episode was without warning, but occurred while he was standing. Now, he subsequently suffered 2 additional near syncopal episodes over a 2-week period and sought medical attention at the outside hospital where he had his pacemaker implanted. Which is the most likely cause for his syncope? So syncope after pacer implant. Number 1, or A, vasovagal episode or neurocardiogenic episode. Could this be VT? That's B. C, device or lead malfunction. D, pacemaker syndrome. Or E, pseudosyncope. Yeah, he's just making this up. So if you want to volunteer or put your sort of choice in the chat, Ralph's going to take a peek at it. So statistically speaking, what is the most likely cause for his syncope?
You have a couple of C's, a B,
Okay,
a B, a D.
excellent. So generally speaking, the most common etiology for syncope after pacemaker implant is neurocardiogenic syncope for 2 reasons. One is sometimes pacemakers are put in for neurocardiogenic reasons. And for the most part, pacemakers really don't prevent neurocardiogenic syncope. That's one possibility. And the other possibility is that neurocardiogenic syncope is the most common cause of syncope. And a lot of these patients who get pacemakers are also on vasoactive medications, making them at risk for having hypotension. It's always easy for the emergency room to blame the pacemaker. Oh, it's the pacemaker. It's not working. The chances of pacemaker failure is extremely low. But this case gets more interesting. So how would you go about evaluating something like this? Well, a device interrogation is mandatory, right? We want to get a sense of what the pacemaker is doing. Potentially, we could have recorded some electrograms, which might, sort of at the time of the syncope, might give us a clue as to what's going on. An echocardiogram can be useful if somebody hasn't had an echo and they have heart block and they've had RV apical pacing. Maybe they've developed a cardiomyopathy. Maybe this person had an episode of ventricular tachycardia. Certainly that's on the differential that I presented. Other tests that you can do, tilt table tests, probably not useful, but you can if you're really suspicious of neurocardiogenic syncope. Though remember, you can make a diagnosis of vasovagal syncope with history and physical exam. EP studies generally not useful, X-rays, we do this all the time, but it's unusual to find things on X-ray to really make a true diagnosis. So this was his interrogation. This was at the time, around the time that he was transferred to us. So at the outside hospital, the doctors there thought this person had a lead fracture or something. And so they programmed him DOO at 80 beats per minute and sent him over to us for a lead extraction. When we did an interrogation, we checked his our right atrial and right ventricular leads. The threshold looked fine. The impedances relatively looked fine. He was pacing 100% in the right ventricle. He's pacer dependent. But there were two episodes here that our device technician kind of mentioned, that the electrograms revealed a 4.5-second pause with V-pacing inhibition. So let's take a look at that. Here it is. So you can see the atrial channel, the ventricular channel, the marker channels, and you can see here the A's going through. But you basically see this non-physiologic, what we consider noise, saturating the amplifier. Non-physiologic, you can see 150 beats per minute here. 150 milliseconds, sorry, here. All right. This was his pacing impedance trend. There was kind of a spike here. And there is some abnormalities here, right? Remember, his device was placed in 2011, and he has not had any intervention since then to his device. We start to see some fluctuations in his lead impedance. Thresholds were fine. You can see pretty stable. So we did an X-ray. I said, even though X-rays may not always be useful, once a non-invasive, readily available, and you take a good look at his lead, I don't see anything here. You have to take my word for it that we magnified the X-ray, went down his lead. There was no microfracture or obvious, there's no break, certainly, or macrofracture or a break. But we also wanted to pay attention to the header. And if you pay into the header, does anyone want to mention in the chat what they see on the header?
V-lead set screw.
Okay, good. So by convention, here's the pacemaker battery or generator. By convention, the top port is the atrium, bottom port is the ventricle. Notice that the pacing lead pin is through the distal set screw here in the atrium. You're missing that in the ventricle. And so this person, we talk about a loose set screw. That's certainly one possibility. Or in this case, the pin was just not pushed in past the distal set screw. In this case, back in 2011. And the interesting part of this case is that the patient had really no syncope until about 5 years later. Now, remember, he didn't feel just right after pacemaker implant. There could have been some sort of make or break connection involving this pin header confluence. And of course, at the time of generator and exploration, you can see the pin going through in the atrial lead, and this is missing in the ventricular lead. So the teaching point here is that device malfunction is an infrequent cause of syncope after pacemaker implant. Remember that. But you do have to, once again, go through this sort of in a steadfast way, to rule in and rule out certain things about pacemaker function. So device interrogation, extremely useful. Now, we've seen examples of lead fracture, insulation failure. They're the most common causes of device failure, certainly noise. But don't forget these make or break issues like loose set screw, microfracture, or electrical connection problems. And the interesting part of this case is that it seemed to be manifest literally 5 years after his initial implant.
All right, let me ask you a question.
Yeah.
Did you leave the lead?
I did.
All right.
I did not extract the lead. We're an extraction center, and we were ready to do whatever. Once we saw the X-ray that this was most likely a pin issue, and remember, the saturation of that amplifier and that noise was very, very suggestive of maybe sort of electrical EMI, that type of interference or make or break. And we decided to leave the lead. And now we did this case in 2016. I just saw him in clinic literally 3 months ago, and he's doing fine with no further.
That will also cause significant changes in impedance, you think?
Well, if you take a look at his trends, right, his trends, there was a little bit of a concern in his trends that something was going on. Now, what I didn't show was his previous trends, and we don't have that available, but based on his previous interrogations from the other hospital, because he's had routine clinic visits, his impedance was quite steady. And so I didn't think this was a lead fracture. So I took the gamble of keeping the lead in and taking that chance, and he's done well.
Because I do want to point out to the group, we didn't really talk about this at all in the lecture, so I think it's important to know when you get a value for a lead, if I say, well, the impedance is 600, and that's clearly kind of right in the mid-range, are you happy about that all the time? The answer should be no, because you need to know what it had been. So, 600 is well in the normal range, but if it had been, a high impedance lead that was 1100 or something like that, and the next time you see them at 600, that's a bit of a concern. Or if for whatever reason where you placed it, it had an impedance for years of 300, and then it goes up to 600 or 700, that may be a little bit of a concern. So you really do, you like the impedances to be pretty stable over time, and most times they certainly are. So a specific number doesn't rule in or rule out a fracture or an insulation failure. Again, usually they can be way high or way low, but it can kind of point that something may be wrong or heading in the wrong direction. So you like your impedances to be stable regardless of where they are. And if you're implanting a device, it's kind of nice to have a relatively high impedance, because you'll kind of use a bit less energy, a bit less battery, if you will, by pacing with higher impedances and a high impedance lead.
Great point, Ralph. All right, so let's move on to case number 4.
One other question says,
go ahead.
Was anything done at this is from one of the folks here, was there anything done at the time of the jump in impedance to 1500? So was there anything that you thought you think it was just related to it kind of possibly moving a bit?
Yeah, I think this was sort of a make or break situation where at times there was enough of the pin at the set screw level that there's no issues. And then, with manipulation of the pocket potentially of his arm, there could have been more of that make or break. So that might have represented those spikes in the pacing impedance. Nothing was necessarily done at the time at the outside hospital when they saw those changes.
Great, thank you.
Okay, case number 4 is a theme of ICD shock during exercise. So it's a 47-year-old man with hypertension, CKD, non-ischemic cardiomyopathy, underwent subcutaneous defibrillator implantation in December 2016 for primary prevention. He has known asymptomatic paroxysmal atrial fibrillation and is on Eliquis 5 milligrams BID in addition to guideline-directed medical therapy for his chronic systolic heart failure. He presents to the clinic after suffering a shock while using his elliptical machine. He denies chest pain, palpitations, or dyspnea on exertion. So for those of you who are not familiar with the subcutaneous defibrillator, it's a totally non-transvenous system. Is placed, the generator is generally placed in the mid-axillary line, and the lead that's connected to that generator is tunneled underneath the breast, the chest, and so it sits right above the sternum. And the device senses what we call subcutaneous electrograms or subcutaneous signals. And the sensing is programmed either primary, secondary, or something called alternate. So this was his initial interrogation when he came to clinic. And the device is able to sense whether or not somebody's had atrial fibrillation. So it's able to sort of distinguish sinus rhythm from atrial fibrillation, mainly based on rate. And you can see from the initial interrogation that the sensing configuration is primary. He is set at a very high shock zone at 250 and a conditional zone at 190. What does that mean? The conditional zone at 190 allows, for example, some discrimination of subcutaneous signals. The shock zone is just basically rate-based. And so what we like to do in these patients, especially if they're younger, is to set the conditional zones and the shock zones high to prevent inappropriate shocks from, for example, atrial fibrillation or supraventricular tachycardia. So he was programmed very, very well, and so to minimize inappropriate shocks. And here's an episode of what appears to be AFib. These are the subcutaneous signals. The S means that it's sensing. You can see the irregularity of the signals here. So this is AFib. This was not his shock. Now I'm going to show you some electrograms of his shock. So this was the episode. It was a treated episode that occurred. And you can see here, it's sensing, sensing, sensing. And then all of a sudden, something happens here. And I'm going to go forward. Now it's seeing this. T means sensing some abnormality, tachycardia. And this is the shock that's delivered. Good impedance of 81 ohms. And then back here to sensing again. Okay. So once again, this is his episode. He's on the elliptical machine and then gets shocked. Steps off the elliptical machine and calls us. Okay, once again, you can volunteer or place your choice in the chat. What is the most likely cause for the shock? Is this atrial fibrillation with rapid ventricular response? He has a history of PAF. We saw AFib on the interrogation. Is this sinus tachycardia because he's exercising? Is this T-wave oversensing? We saw an example of that earlier. Is this VT? Or is this loss of sensing signal?
We have a bunch of E's so far uniformly.
Oh, good. So not rocket science, right? We saw basically that we see a disappearance of the subcutaneous electrogram. There's loss of sensing signal. It's possible that maybe the patient was leaning forward as he's doing the elliptical, he's moving in a different way, and then the vector may be changing, how the sensing is doing. So certainly the answer is yes, loss of sensing signal. And here's the treated episode. You can see that we have that certain loss, and then there is sort of picking up of extraneous signals instead of seeing what the true subcutaneous electrogram should look like. But here's the bigger question. What would you do to avoid another shock? All right, A, do you tell him not to exercise? B, do you replace the subcutaneous defibrillator with a transvenous system because he wants to exercise? Do you change the sensitivity? D, do you reprogram the sensing vector? Or do you change the detection in the conditional zone to 220 beats per minute? This is a harder question. What are your options in the clinic?
So far, 4 Ds as a
D,
go.
good. Okay. Well, we don't want him not to exercise, not a good idea. We encourage our patients with heart failure and cardiovascular disease to exercise. So that's not a good idea. And it makes no sense, right? We want him to exercise. We don't need to replace the subcutaneous defibrillator with a transvenous system. It's not necessary because there are other things that we can do. And given the fact that he has kidney disease, right? We believe that patients with kidney disease do better with subcutaneous devices than transvenous devices. We cannot change the sensitivity on a subcutaneous defibrillator, right? Remember, we talk about changing sensitivity with transvenous systems, but the subcutaneous defibrillator doesn't allow us to do that. It's one of those things. It sees it or it doesn't see it. But what we can do is reprogram the sensing vector. So remember, this subcutaneous defibrillator, and I'll show you a graphic, is able to sense through 3 vectors. Now you might say, well, what if I change the detection in the conditional zone to 220? That's not going to help because when you lose sensing signal, it's going to sense things that are going to be much faster than 220. So that's not necessarily going to help this person. And so remember the subcutaneous defibrillator. Here's the generator. Here's the subcutaneous coil. Here's primary, secondary, and alternate. And so remember, he was programmed primary. And remember, the device automatically picks the sensing vector based on signal quality, amplitude, stability. But as the implanter, as the following physician, you are able to change that sensing vector. So when we change the sensing vector to alternate, you can see that the electrogram, the subcutaneous signals, I should say, are a lot more smaller, diminutive. And there's a concern that we may not be sensing well here. So when we changed it to secondary, was better. You can see that the electrogram amplitude was larger, but there's also a chance that it may not sense completely. Given that he had the shock in primary, we decided to change him to secondary and then put him on a treadmill. We didn't have an elliptical machine in our office to kind of mimic what he was doing, but we thought maybe with just sort of increasing heart rate and exercise, will we see the same loss of signal? At least with secondary, we did not see any loss of signal. And then on follow-up, he was asked to go ahead and resume his elliptical machine at home. And so far, he has been fine without any further shocks. So the subcutaneous defibrillator has sort of unique things which we do not necessarily see with transvenous systems. So loss of sensing signal, though it's not common, something you may encounter when you take care of these type of patients. Okay. Case 5, the theme from case 5 is managing alert from remote monitoring. So remember that all of our patients with implantable devices should be placed in remote monitoring. In fact, it's a class 1 indication from the Heart Rhythm Society guidelines. Why is remote monitoring important? Well, remote monitoring of devices has been shown to reduce morbidity and mortality in patients with pacemakers and defibrillators and BiPAP devices. So here's a 75-year-old man with ischemic cardiomyopathy. His ejection fraction is 28%, severe COPD, had a cardiac arrest, and had diabetes, underwent ICD implant as secondary prevention. Now, he has no previous history of atrial arrhythmias or stroke. His medications include lisinopril, carvedilol, aspirin, and Lantus insulin. Your device nurse brings you a copy of his remote interrogation. There was an alert that was sent via his home monitor. And when the nurse logged on to the website, found that this alert was there and downloaded the information and has given it to you to evaluate. And patient's completely asymptomatic. The nurse called him, he feels fine. So here was the remote interrogation finding. And you can see here, though, this is a right-sided defibrillator. And this is a device manufactured by Biotronic. Because of his bad lung disease, you can see his heart's just shifted over. This is the ICD lead. And this is actually a virtual bipole that's floating in the right atrium. This virtual bipole allows the defibrillator system to sense what's happening in the atrium. So for example, if you have somebody with complete heart block and sinus rhythm, you can provide atrial sensing with synchronized then ventricular pacing. But in this case, this virtual bipole that's floating in the right atrium is picking up this. And what we believe this is a run of atrial fibrillation and or atrial tachycardia. And this episode here lasted for 24 hours. So the question is, how much atrial fibrillation is associated with stroke risk when you see these type of electrograms or events on patients who have implantable devices? Well, remember that the ASSERT study, which was published, I'd say in 2012, was one of the first studies which sort of brought this to light, where having 6 minutes of an atrial tachyarrhythmia, and they defined atrial tachyarrhythmia as anything greater than 190 beats per minute that lasted more than 6 minutes, was associated with an increased risk for stroke. And that caused sort of an uproar amongst the electrophysiology community saying, oh my goodness, 6 minutes of this could increase stroke risk. Now, since that time, subsequent to that, there have been multiple studies done, longitudinal studies, retrospective reviews, meta-analyses, looking at whether or not device-detected atrial tachycardia is important and in fact confers a higher stroke risk. And I thought this paper was nice in that it looked at 20,000 patients that were enrolled in 3 device type of studies, the panorama study, trend study, and then clinical service study. All of these patients did not have previous atrial arrhythmia history, but these patients were then followed over time, and then retrospectively they were reviewed to see whether or not they developed atrial fibrillation. And they found that the prevalence of device-detected atrial tachyarrhythmias in a group of patients that previously had no atrial arrhythmias was quite high. So you should suspect that these patients that have devices will develop this. Why is that? Well, it makes sense. The same risk factors that led to cardiomyopathy are most likely going to lead to atrial fibrillation. The question is, how much atrial fibrillation is important? Well, ASSERT said 6 minutes. And in this review, they felt as if greater than an atrial fibrillation or a device-detected atrial tachyarrhythmia around 1 hour was an important sort of marker for stroke risk. Now, this is a moving target. We have a lot more data coming out on looking at whether it's 1 hour, whether it's 6 minutes, whether it's 6 hours. Once again, is it the total duration of atrial fibrillation, or is it atrial fibrillation burden, right? Devices can give you a burden of atrial fibrillation as well. Is burden important if it's 1%, if it's 3%, if it's 5%? Once again, moving target right now. So how do I approach it? Certainly in our device clinic, if anyone has 6 hours of atrial fibrillation or device-detected atrial tachyarrhythmia, that requires an investigation. What I mean by that is that I'm going to open the medical record for that patient, review what's going on, calculate a CHA2DS2-VASc score, and then determine whether or not this person is or is not on anticoagulation, and at least have a conversation with that patient about what this means. So that's kind of our practice pattern here at the University of Chicago when we see something like this.
And is that a 6-hour episode, or is that a 6-hour total burden?
Excellent question. So right now we're using two things. We're using a 6 hour, any episode lasting more than 6 hours. And then we're using an AFib burden of around 5%. That's arbitrary, like I said, moving target. And once again, it all depends on kind of that individual patient. So I might be more worried about a patient who may have an AFib burden less than that and be aggressive about anticoagulation. But that's currently kind of what we tell our device nurses to bring to our attention when they see something like this. I thought this was kind of interesting. People always talk about, well, you know, is paroxysmal atrial fibrillation more associated with stroke risk, or is having permanent atrial fibrillation associated with more stroke risk? In my mind, as an electrophysiologist, the more AFib you have, the more stroke risk you have. And this was kind of a nice meta-analysis, which basically said non-paroxysmal atrial fibrillation may actually confer a higher risk, which makes intuitive sense. But it doesn't really matter, right? You can have PAF, persistent AF, permanent AF. All three conditions will carry stroke risk.
Another question from the audience. Can the pacemaker differentiate flutter, fibrillation, and SVT?
Excellent question. So it depends on the rate. So you can, for example, you are able to program the atrial rate that you want recorded and alerted to you. And so sometimes very fast SVTs can fall into that category, and you may get an alert. Well, how do you differentiate the two? By looking at the electrogram. Same thing with atrial flutter. Atrial flutter will have a fast atrial rate that will be recorded and sent via alert. How do you tell the difference? You look at the electrogram. And when the example I showed you showed sort of atrial tachyarrhythmia. What I didn't show you was that eventually that tachyarrhythmia degenerated into atrial fibrillation. That was clearly seen on the atrial electrogram. Okay, so the teaching point of this case is that device-detected atrial tachyarrhythmias are very common. They are associated with increased thromboembolic stroke risk and should be taken seriously. The duration of the device-detected atrial tachyarrhythmia, as well as the calculation of total burden, are useful measures. And once again, this is a moving target, and I think we're going to get more and more information about this over the next few years. Most important thing is that we are champions of oral anticoagulation as heart rhythm specialists, as well as cardiologists, and as well as folks that take care of cardiology patients. Remember that oral anticoagulation is the most important thing you can intervene upon to reduce this patient's risk of morbidity and mortality. Okay, case 6, I label putting on your EP glasses. So we have a 37-year-old man with hypertrophic cardiomyopathy, status post single chamber ICD implant in 2018 for primary prevention sudden cardiac arrest. He presents to the emergency room complaining of palpitations. While there, he receives an ICD shock. He denies chest pain, dyspnea, and exertion, previous shocks. The device rep interrogates the device and sends you the following stored electrograms. So once again, this person had has a St. Jude device defibrillator. The patient has had 3 or more VT-VF episodes in 24 hours. You can see that this was the episode in question here. A dysrhythmia or something was detected. The detection criteria was set at 214 beats per minute. The device delivered ATP that apparently didn't work. And then the patient required a defibrillation. And then the the rhythm fell below device detection, as you would expect after shock. This was a true arrhythmia. Shock impedance, everything was normal. Charge time was normal. The event in question had a fast heart rate of 222 beats per minute, which met detection based on what it was programmed. You can see that there. So this is the interrogation in question. Remember, this person is in the ER for palpitations and gets a shock while he's in the ER. And so once again, a near field, far field electrogram. So what do we mean by near field? So near field electrogram for an ICD is, what is the ICD lead seeing? So a near field electrogram is generated when a wave of depolarization is heading towards the tip of the ICD lead. And it's basically seeing between tip and ring, giving you a very narrow focus or view of what's going on. The far field electrogram is generated when that wave of depolarization hits the ICD lead, and it's been recorded between the tip of the ICD lead and generally the coil. So, that's the distal coil. It gives you a broader view of what the device is seeing. And the markers sort of tell you what the device is interpreting and looking at. So we have these V senses. We see that here. And we see a change in rate that we see here. The device is now calculating this and saying, okay, it's getting fast, getting fast. Once again, it meets detection criteria. Here's the ATP that's given. And then you have a change in this tachycardia, gets faster. And then, of course, this device delivers this 30 joule shock. And then you have this electrogram here. And you can see that there's a change in the electrogram here versus here. All right, so this is the interrogation. Let's go back one more time here. Here's the initial event. Speeds up. ATP. Speeds up again. Shock. Change in electrogram. So here are the questions. Which arrhythmia is most likely responsible for the following electrograms? Okay, so these are the first electrograms in question. Is it A, monomorphic VT, B, sinus tachycardia, C, torsade de pointes, D, AFib with rapid ventricular response, or E, atrial flutter with variable conduction? You can volunteer or place your choices in the chat.
Of 3 Ds.
Okay.
4, 5.
All right. Here's the second question. Which arrhythmia is most likely responsible for the following electrograms? So this dysrhythmia was generated after ATP was delivered. So A is this monomorphic VT. B is this sinus tachycardia. C, torsade de pointes. Is this AFib, or is this atrial flutter?
Got a couple of A's.
Okay, good.
Bit
All
more.
right. So one of the advantages that we had in this case was the patient was in the hospital, and presumably this patient was being monitored. That's very fortunate, because most of the time, patients are not monitored when they get shocks. So how do we interpret what's going on? Well, we look at stored electrograms, right? We basically take a look at what sinus rhythm looks like, or V sensing looks like when they're in normal rhythm, and compare it to the electrograms during the dysrhythmia. And basically what we're looking for are changes in the inscription of the electrogram to say that the electrogram looks different from what we see in sinus rhythm, right? The challenging part of this case is that the electrograms don't seem to change that much, all right? Well, let's go over that. So what we're going to try to do now is correlate the rhythm strip that was recorded at the time with the stored electrograms to highlight some important sort of features. So now I'm going to place the recorded telemetry strip that was recorded when this occurred. So now when you take a look at what's going on here, here's the telemetry strip, and you can see here that this is a fast arrhythmia. It's irregular and fast. So when you say an irregular fast rhythm, what comes to mind? Atrial fibrillation with rapid ventricular response. So good. So the first question was, what's responsible for this set of electrograms? Atrial fibrillation with rapid ventricular response. And when you take a look here, you can see that there's some irregularity here in the R to R intervals that are recorded. Great. Now, what's going on here? So here is the atrial fibrillation. ATP is delivered, which we see here, and look what happens. The ATP actually causes the atrial fibrillation to go into this arrhythmia, and this appears to be fast monomorphic VT. So this is not something we like to see. We don't want ATP to either accelerate dysrhythmias or cause ventricular arrhythmias when you have non-ventricular arrhythmias as the start. So here is that monomorphic VT here. And then we have the termination with the shock. So it's unusual when we get this correlation. Many times we don't, but it's nice to go over this. So now the question is, what's going on here? Why do we see a change in the electrogram after shock? You can see that it gets wider. Certainly it's different than what the electrogram looked like prior to the shock. And we often see this as well. So many times we see an electrogram change after shock, and we think it might be due to aberrancy at that point, or potentially something called current of injury. And we often see this when you have successive shocks. So if you have successive shocks, you can see a change in the electrogram morphology after the shock, and then over time, the electrogram reverts back to normal. Just wanted to bring this up in case you come across it in the future. But sometimes, so when we want to evaluate EGMs to compare sinus rhythm from ventricular arrhythmias, we always say, put on your EP glasses, right? Take a good look at the inscriptions. Well, here's atrial fibrillation, here's the near field, here's the far field. We often look at the far field electrogram more often than the near field because it gives you a broader view. Here's atrial fibrillation, okay? I see that in the far field electrogram looks pretty much like a QS type of configuration here, maybe a little R wave at times. Okay, this is what AFib looks like. Here in the near field, we get this kind of tall R and then a shorter R prime, but that's not always the case. We see a fluctuation here. Here's this monomorphic VT, and we clearly knew it was monomorphic VT because we saw it on the telemetry strip. This doesn't necessarily help us. This just looks just like this. You can make a case, well, maybe this is shorter, maybe this is more of a Q wave here, there's no R wave, but look, there's an R wave here. So the near field electrograms look similar, and the far field electrograms look similar as well, which is why this case was challenging. And it was fortuitous that we had this patient on telemetry that we were able to really tease this out. What's the concept here? The concept here is that most monomorphic VTs arise in the left ventricle, especially in patients who have myopathies, right? And most patients with defibrillators have some sort of myopathy. These VTs, these waves of depolarization from the VTs are hitting the ICD lead generally in this direction, which is the opposite way of what a supraventricular arrhythmia would be doing, right? The wave of depolarization in SVT or AFib would be hitting the ICD lead in this direction, causing a different inscription of the electrogram. That happens about 90% of the time. But remember, there are exceptions. 10% of the time, the electrograms look very, very similar. And sometimes it can be a challenge to distinguish between supraventricular and ventricular arrhythmias. So the teaching point in this case is that, yes, detailed review and interpretation of stored electrograms are critical in determining the etiology of the event of the episode. Because remember, there could be supraventricular arrhythmias, ventricular arrhythmias, atrial fibrillation, and then of course we showed examples of noise and artifact. Most monomorphic VTs will exhibit a change in EGM morphology compared to sinus or supraventricular arrhythmias, but you have to prepare for exceptions. And if you can, if at all possible, correlate with an electrocardiogram or EKG, if at all possible. It will make your life a lot easier in sorting this out. But I thought this was an interesting case in that the far field and near field EGMs really looked quite similar. It was kind of putting two and two together and getting a sense of what could be going on. So I'm going to stop here. I think I have here
Yeah.
we go. Thank you for your attention. I'll be happy to answer any questions that come up.
Great, thank you. There is one question already from the audience. Is it likely that the 10% of monomorphic VTs that look like SVTs will be RV or T tachycardia?
Yeah, that's an excellent, astute observation. Certainly, yes, it's possible that those VTs may be coming from higher up. So once again, hitting the IC lead in that same general direction. So it would make sense that those type of VTs may be coming from the outflow tract region. Sure.
Any other questions from the audience? Do rhythm match features of some devices help when you do not have a telemetry strip available for differentiation?
Yes, absolutely. So remember that the devices have what we call discriminators. And the discriminators, a lot of discriminators are based on morphology. So they basically take a template of what normal rhythm looks like. And then when they have a dysrhythmia, they then compare that template to what the dysrhythmia EGM looks like, and they match. And if it matches, then the device is going to say that this must be supraventricular. It matches what normal sinus rhythm looks like. I'm going to withhold therapy because I think this is supraventricular. I'm going to avoid an inappropriate shock. Remember, though, that the discriminators only function in the VT zone. When an arrhythmia gets very, very fast, falls into the VF zone, there are no discriminators available. And so that's why, especially in younger people, it's important to place the detection intervals very, very high. So you can set a VF detection very high at 240, 250 beats per minute to allow potentially supraventricular arrhythmias to fall into a discrimination zone to avoid inappropriate shocks. So yes, I turn on discriminators. Turning on morphology is a good thing, but sometimes if the arrhythmias are so fast, they bypass the VT discriminator zone and fall straight into the VF zone.
Great. All right, well, I think if there are no more questions, I would like to thank both faculty members, Dr. Singh and Dr. Nayak, and all the faculty of the program for the last 3 sessions. I really think it's been a lot of fun and a great educational opportunity for our fellows. I'd like to turn it over to Mitzi now to end the program.
Hey, thanks, Dr. Verdino. Thank you, Dr. Nayak, Dr. Singh. Appreciate everyone attending as well. So you will be receiving an email from me or from someone on our team with links to these presentation recordings. They'll be available for 2 weeks. And if you have any ideas or requests for future programs, just feel free to email us back with those requests and we'll do our best to accommodate you. So with that, you're free. Have a good weekend, everybody.
Bye, everyone.